there were a tremendous number of important lethal injuries early on, but those people who suffered those injuries in the immediate 24 hours after the quake died. And 250,000 people or more died associated with the quake. What were left were people who had not received lethal injuries, but had received some injury that wasn't going to kill them outright, and who now needed medical care. And we believe that most of those injuries would be orthopedic in nature, since the major injuries to the thorax and abdomen would largely have killed people immediately associated with the event, whereas injuries to the extremities might have been things that people could survive and now need treatment for. So we built a plan for doing this around the notion of going and trying to provide some orthopedic care. We didn't plan on doing fancy things. We thought that the situation would be pretty primitive on the ground, and so we went with the idea of being able to do a small number of important operations very quickly. These might include amputations or wound dressing changes or debridements or other things that would be related to trying to salvage a limb or salvage a life. And mostly that would be done under less than optimal conditions with whatever we could bring along. And so our plan was to take along the stuff that we thought we might need for a couple of weeks and let the situation dictate what it was that we were going to do.
So you went down to do anesthesia, but we talked to you after you'd been there like 5 days and you had not yet done any anesthesia. What did you do?
I did not do an anesthetic in Haiti. I'm an anesthesiologist, but I didn't do an anesthetic. My colleague, Rex Hayden, is an orthopedic surgeon, and he didn't do an orthopedic surgical procedure under anesthesia. Most of what needed to be done at that time was very basic medical care. A lot of it simply trying to figure out what had happened to people in the various hospitals that they'd been taken to and what needed to happen now. Almost everyone who was brought to the Love a Child Field Hospital was someone who had had some sort of surgical procedure, an operation for an amputation of an arm or a leg, some sort of orthopedic application of a cast, an attempt to get the bones put back together, or a placement of one of these external fixator devices. And in some cases, simple treatment of crush injuries, which can create compartment syndromes. And then for these, the treatment is to open up the skin lengthwise along that compartment to relieve the pressure so that the pressure doesn't destroy nerves and tissue in that compartment. These compartment syndromes happen in the arms and legs when they're crushed, for instance, by concrete, which is a very common sort of injury. So a large number of people had these open wounds that now needed to be cared for. My colleague Rex and the two Creole-speaking nurses, Elvire and Nicole, were able to see these patients as they were brought to the Love a Child Field Hospital and determine by talking with them and by examining them what had happened to them and what kinds of treatments they had obtained and what sorts of things needed to happen next. And really they were queuing up all the activities of the Operation Smile folks, getting them aligned so that they could have subsequent operations, and in many cases simply taking care of people in the triage tent. Rex would unbandage the injured extremities and examine them, clean some wounds, debride some tissue, realign things, and then bandage things up, and we'd plan for the medical care of these people. And that was primarily the medical activity that we were engaged in. There were also people who came with other kinds of injuries or conditions, not strictly orthopedic. So we saw patients with malaria, with TB, with AIDS, with dysentery and diarrheal illness, with probably pulmonary contusions from crush injuries, some head injuries, a lot of skin lacerations, a lot of abrasions, and of course malnutrition and dehydration, which follow in the wake of these accidents or catastrophes. And so a lot of the care in the triage tent was directed at these sorts of things. And my colleague Rex Hayden, although a sophisticated orthopedic surgeon, stepped up to the plate and did a whole bunch of regular medical care as well.
You did some non-medical things as well too. I mean, you essentially wired the camp.
Everybody did non-medical things. It was absolutely essential. You're a doctor, but you're also the person on the scene who knows how to do stuff, and so we did a lot of things. We had the our folks who were supplying us here from the University of Chicago had the foresight to include some things in our kit going down that might have seemed a little bit odd to some people, but among them were a string of work lights, the kinds of things you see on construction sites that provide lighting before the electricity and everything is installed in a building. And we took these work lights and immediately set up some electrical wiring that allowed us to light the triage tent, which was a big advantage because in Haiti, when the sun goes down at 6 or 6:30 in the evening, it gets completely dark very quickly, and there's no other light. And so if you have people come in the middle of the night or who are already there and need continued care, there's nothing but flashlights to work by. But there was a generator on site, and we rigged up a bunch of extension cords and wires and hung the string of work lights, and were able to light the triage tent at night and gradually to extend some lighting. Working with the Haitian staff in the field hospital, who were very inventive, we're able to extend some light to some other areas, including some of the campsite areas for the patients and some of the other parts of the facility, including the pre-op and post-op tent and the operating room, so that we could, if needed, take care of patients at night. It's pretty hard to evaluate orthopedic injuries and orthopedic repairs without an x-ray machine, but we didn't have an x-ray machine for most of the time we were there. Near the middle of our time there, we did get the use of a veterinary x-ray machine that allows you to make some fuzzy pictures of broken bones, but very poor quality compared to what people are used to. So there were a lot of technologies that we didn't have. We didn't have x-ray, we didn't have an EKG, we didn't have any clinical laboratory until our Ecuadorian friends brought a small microbiological laboratory with a microscope. We had no chemistries. We couldn't measure any of the serum values that we normally would measure. We didn't have the ability to spin a hematocrit, so we couldn't tell what anybody's blood count was. But all of the things that those technologies tell you are also things that your senses can tell you, not as accurately and not as quickly and not as precisely, but clinicians with lots of experience can tell when someone is anemic, and can tell when bones are malaligned, and can tell when wounds are infected, and can tell when patients are dehydrated. And so my colleague Dr. Hayden and our nurses were capable of doing that and figuring out what was actually going on. To call it psychic orthopedics is to say it's orthopedics done by clinical judgment alone, and I think to call it psychic is in a way to denigrate the great skill of the people who are doing this, because what Rex was doing was calling on all of his orthopedic knowledge and skill, which is extensive, to make assessments and decisions and care plans without having all this technology, which he did exquisitely well, and everybody agrees with that.